Glossopharyngeal breathing. GPB is a technique for essential breathing support and/or secretion clearance for individuals with weak inspiratory and expiratory muscles and decreased lung volume. When performing GPB, the air naturally enters the oropharynx through the open mouth as the base of the tongue moves downwards. Lips close, trapping air in the pharyngeal space. The tongue moves upwards to the soft palate, forcing the bolus of air through the pharynx and open glottis. The glottis closes and the air is trapped in the lungs. The piston action of the tongue, pushing boluses of air one on top of the other, is repeated until the desired lung volume is achieved. When first performing GPB, it is useful to use the word gup to assist with proper positioning of the throat muscles. This is Brad's first attempt with GPB.
In the learning process, you say the word gup, but with minimal voice volume. I'll demonstrate. So the G actually positions the tongue, the ball of the tongue in the proper position, and the P closes the lips. So you repeat sequentially, and that promotes the stroke movement of pushing that bolus of air beyond the pharynx. Let's try just the sequential gut movement for now. Let's try to do 10 to 15 in a row. Okay. We'll do it together. Big breath in first. You can let it go.
Dino also performs GPB. To assess his technique, we measure with a right respirometer the gup air volume, which is the bolus of air pushed beyond the pharynx by the piston action of the tongue, and it is proportional in size to the descent of the base of the tongue. In this instance, Dino's gup air volume is more than acceptable at 100 to 125 ml. To assess the clinical benefit of GPB, measure and compare spontaneous vital capacity with and without glossopharyngeal breathing. First, perform a baseline vital capacity without GPB.
Big breath in, and squeeze it all out, push it 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 out. If there's nothing left, big breath in. Big breath in, and start GPB.
The vital capacity is then repeated with GPB. This lung volume is referred as the maximum sufflation capacity, MIC. Brad's baseline vital capacity is 0.8 liters without GPB, 15% of predicted normal. And his MIC lung volume with GPB is 1.46 liters. 27% of predicted normal. The difference between the MIC with GPB and spontaneous vital capacity is 0.66 liters, a lung volume recruitment improvement of 83%. A strong cough is critical for effective secretion clearance with individuals who have weak inspiratory and expiratory muscles. And for this reason, it is essential to measure and compare peak cough flow with and without GPB. The baseline peak cough flow is measured without glossopharyngeal breathing. Dino takes a maximum spontaneous breath in and coughs through the peak flow meter. Dino's peak cough flow at baseline is 210 liters per minute. To measure the peak cough flow with GPB, Dino takes a maximum spontaneous breath in, followed by glossopharyngeal breathing to maximum insufflation capacity. He then coughs through the peak flow meter. And with GPB, his peak cough flow improves to 295 liters per minute, well above the 270 liters per minute peak cough flow recommended for effective lung secretion clearance. Visit our website at www.canventottawa.ca for additional comprehensive information.